problem is they sometimes last a while. Even if the person stopped using it, it will keep on going for a while. That makes it harder to treat. There was one case study in Britain where the patient was admitted for 12 days in the psychiatric hospital due to paranoia from bath salt, or they call methadone, which is one of the ingredients. And he got treated with antipsychotic medication monthly. Upon discharge, he didn't even relapse. He became psychotic again. And the other challenging thing also is we see waxing wane of psychiatric symptoms. So they come in, they're extremely psychotic first, and then within a few hours they seem clearer, and then a few hours again they have the recurrence of symptoms. So it's very hard for us to kind of manage in some sort of way because we can't consistently see a pattern of behavior. Other things that we see, certainly it's the danger is going to affect other people in terms of family members who use it. But one of the concerns we have about kids, for example, is that caregivers may be using this drug, and as a result, leading to neglect of the children, or even worse, the kid can pick up the drug. I mean, the drug has nice innocuous names like bath salts, white ivory, kryptonite. You can easily, the kid think, oh, this has something to do with Superman, and they may inadvertently take it. Remember the old days when ecstasy came out, that little Simpson head? People used to sell that as a way to get kids to use it. I mean, it hasn't gotten to that point in terms of a pill because it's a powder, but it doesn't take much powder to get someone really going. Almost a little dab. So, I have an 11-month-old son, and I can imagine a little kid just touching this stuff and putting it in his mouth, and next thing you know, something bad happens. So I think it's really scary. And certainly, as Chief said, people are cutting this stuff now, with combining it with other drugs. Why people use this? I mean, Chief mentioned some of the reasons. Causes could be one thing. I had a patient recently told me that, it's the cost. If cocaine was this cheap, I'll use cocaine. But, because cocaine is so much more expensive and this is only a couple bucks, I'm going to go with this instead. So I think that's certainly a big thing that drives it. What kind of people use bath salts? I mean, we see a variety of folks. Unfortunately, we don't have a lot of studies to tell us what, from anywhere that tells us, what are the characteristics of these folks who use. Even the studies from the UK, which is probably the one who's seen the most exposure, are kind of limited. And my colleagues who are over there have different kind of reports. But there was one report from the CDC that looked at a health department in Michigan, and they found that approximately 50%, almost 46 to 50% of those folks who use had a co-occurring, what we call like simultaneous psychiatric illness. It could be depression, it could be schizophrenia, and so forth. And approximately a third also had substance abuse issue. So, you're not talking about people who never experienced drugs and never had psychiatric illness, but you're talking about vulnerable groups who are already, at risk to using. And again, they could be using to self-medicate for a variety of reasons. It is a public health concern. I mean, this is a problem that doesn't involve the chief, doesn't involve us at Acadia, the psychiatric piece. It doesn't involve only Jonathan Roscoe and the folks at Eastern Maine University. This is a public health issue that requires a multi-pronged approach. It requires law enforcement intervention as well as treatment from everybody. And again, it's not just us. You folks are going to be playing a key role in prevention. I mean, these forums of education, you guys are going to take the message home. You guys are going to bring the manners to folks who may even think about using this drug and say, hey, this is nasty, don't touch this. Some people will listen, some people will not, and we just have to keep trying. And one of my hope is that this won't be the last forums we will do. We will keep doing this. We have an opportunity here, folks. I mean, when I started psychiatry, I came into a society that already has to deal with cocaine, heroin, and marijuana. Bath salts is fairly new to us. We have a chance to do something now, to not take it away totally, but at least stop the flow and make it a little easier for us to live with. So, with that, I'll open for the questions.
Thank you, Dr. Probably next to the police department and law enforcement, ground zero for this is emergency medicine.
And our next speaker is sometimes the first person that someone who's been arrested on bath salts sees. First place they often go is Eastern Maine Medical Center, and our next speaker has much direct experience working with people who are suffering from the effects of taking this drug. Dr. Jonathan Busco, emergency room doctor at Eastern Maine Medical Center. Doctor.
I moved to Maine from Charlotte, North Carolina about 6 years ago. And in Charlotte, we saw a lot of crack, some cocaine, fair amount of meth. Really not a lot of opiate abuse. People weren't using Vicodin or Percocet. And I came up here and I found that the drug abuse up here tended to be more towards the sedating medications, the benzos like Xanax and Percocet and Vicodin and methadone. And in some ways that was really nice because those patients were so much calmer and much, much easier to deal with. And so in January or February of this year, when we first started seeing bath salts patients coming back in, it was a real shock for all of us in the emergency department. We just don't have the volume of stimulant abuse of people coming in revved up and high. Sure, some people crush Ritalin occasionally and shoot it up, but we really don't see a lot of that up here. And so it was a real eye-opener for us, and we very quickly began to get a sense of what we were seeing and sort of divided these patients into 3 groups. The first group, there's not a lot of them, are the euphorics. These are the people who come in, they're high, and the reason they're there is because it's a really lousy high, and they're not happy about it, and they want us to do something about it, but they're not paranoid, they're not psychotic, they're talking to us, they just want the high to go away. So we're like, well, you can sit here, I guess, but there's nothing we have that reverses this. The second small group we see is at the other extreme, and that's the group we call the toxics. And those are the ones who come in with very bad physiologic effects from the drugs. So high heart rate, they lose control of their body temperature, so high temperatures, 107, 110 degrees. And they come in sometimes in cardiac arrest with their hearts no longer beating. And so that's a toxic emergency. And so that group, not a lot of those, but very resource dependent and intensive. And then the middle group is the one that we see the most of. And these are the ones that we're really identifying with, and the ones that we look at these patients in the emergency department and we think, how could anyone be wanting to use this if this is the high they get? And that group is the psychotics. And those are the patients who come in and they may be able to talk to us, they may have some sense of where they are, but they are delusional, they're hallucinating, they go in and out of awareness. So they may at one time be fine and feeling relatively calm, and next thing you know, they're crawling around on the floor, they're licking the sinks. We call it a positive bath salt sign when we walk by a room and the mattress is on the floor and the bed is out of the room, because these patients aren't safe. They don't know who they are, they don't know where they are, they're trying to climb off of beds. And this group is really resource consuming for us. So if you come in and you're a multi-trauma patient, you're going to be met by our trauma team, 6 to 8 patients. If you come in and your heart stopped beating, you're in cardiac arrest, 6 to 8 providers, all right. If you come in and you're having a heart attack, there'll be 5 to 6 of us in the room. These are our sickest patients. And when these psychotic patients come in, it's the same sort of thing. We need 5 to 6 people in the room to control them. So they're consuming the same resources, the same number of people and personnel and time that someone having a heart attack would have. And the biggest issue for us has been that most of them don't have overt or outgoing psychiatric disease. They're there because of their bath salt abuse. And after 3 to 4 hours, they may clear. But we're seeing people without redosing relapsing up to 72 hours later. And it is a really hard thing to look at a patient and say, okay, you're doing better, I want to discharge you home, and come back 5 minutes later and they've closed the door of their room and they're trying to jump off of the bed thinking that they're diving into a pool. It's just very tough to deal with these people. And the question then becomes, how do you send someone like this home? What do you say to the family who comes to pick them up? Well, keep an eye on them for the next 3 days, because you never know when they might get psychotic and think that you're a demon trying to kill them. I mean, that's not the best discharge instruction in the world. So